Okay, thank you. Thank you very much. I'll commence. Okay, thank you very much. And sorry, apologies for that inconvenience. So clearly there is a long history of lessons in the pandemic preparation and response, and our response today builds on many learnings, but for each new pathogen, there are new twists and turns that need to be uncovered. And it's been very pleasing to see the international collaboration that's been in place to generate that evidence promptly in regard to COVID-19. Some of the challenges, though, with the rapid generation of evidence has been that often the evidence is perhaps not fully formed. There are gaps, and we do require to critically appraise that evidence as it's published so rapidly to ensure that the lessons learnt from that are robust and accurate. And so keeping a very inquisitive mind, critically appraising new research findings, and also translating very much the context of those research findings into the Australian context is an essential aspect of informing our response. Next slide. Some of the lessons learnt from SARS-CoV have been about the ongoing risks and importance of surveillance and global cooperation. We've also learned a lot of fundamental learnings around the transmission patterns and how to prevent the disease. So it's almost difficult now, where we know so much, to remember how we felt back in February of 2020. The thought that we could actually prevent the introduction and sustained transmission of a respiratory pathogen that was asymptomatic, or that had was infectious period prior to symptomatic onset, was something that we probably thought was not possible at that time. So some of the things that we've learned about the virus, as I said, is its mildness, the asymptomatic nature of some of the infections, and the pattern of disease in children is also very atypical compared to the fact that generally we think of children as those that are most likely to spread COVID, or spread infectious diseases. So I think in that point, one of the key lessons has been not to hold on to drawing analogies with existing viruses, but being prepared to receive new information and act on that and change your pre-existing views. And obviously you have to have a starting point, where for COVID we clearly thought, how does it relate to existing coronavirus such as SARS? But clearly we've had to change our considerations of when people are most infectious and how the disease is spread. What's also been clear is that a lot of these novel viruses, including SARS-CoV, have often seemed to have amplified impacts on healthcare workers. And I think that's a key lesson that we need to remember to embed solidly in our response. That was something we anticipated, but I think we see it time and time again with some of the emerging pathogens in the context of a pandemic. Next slide. We also have significant structures that are responsible for incorporating and reviewing that evidence and assimilating that evidence to inform the world. But what's important is, as we look at that evidence and those guidances from the World Health Organization, it's important that we also again do that translation piece to the local context, and that's so critical for research. Next slide. In Australia, local expert advisory groups formed by experts in multiple disciplines have been a key cornerstone of the response. So there's the Australian Health Protection Principal Committee, which is made up of Chief Health Officers, the Commonwealth Chief, led by the Commonwealth Chief Health Officer, but also has a number of academics from disease modelling and infectious disease expertise and infection control expertise. The Communicable Disease Network Australia is similarly a mix of jurisdictional and Commonwealth communicable disease control staff, plus also additional experts. The Public Health Laboratory Network, and I think this has been one of the key strengths in our response, has been our ability to stand up laboratory testing and scale that effectively. Infection Control Expert Group has been chaired by Lynn Gilbert, and again been key to those recommendations about how we can prevent transmissions in aged care facilities and healthcare facilities in general as important settings. Also currently, the Australian Technical Advisory Group on Immunisation is providing expert advice to government on the safety and efficacy of the vaccines, and also the risk prioritisation group. So again, this reflects the fact that Australia has had a very evidence-based response, relying on experts. And one of the key components is that these experts are often engaged in these formal structures all the time. And so those relationships, those capacities to work effectively have been established over a long period of time. Next slide. One of the key aspects of our response has been effective public health response. And again, this is built on a lot of existing investment in public health capacity, but it's also been guided by a recognition that we need to measure and monitor and continually refine our response. And so we've set up these publicly transparent reporting of some of the key disease control points that we need to have in place. And I think that holding ourselves to benchmarks, publishing that, has led to a continual refinement of and a strive to how we can do things better. Next slide. And now I want to talk about some of the targeted research activities in New South Wales. And from the get-go, we really recognised that we needed to learn many things, and that Australia could contribute to knowledge generation in some key areas. And that was because we were, even in wave one, relatively mildly impacted compared to overseas jurisdictions. And so one of the key elements was identifying the sorts of research that Australia could contribute to. And that was really guided by that understanding that we were a low prevalence country, and that was our intent to remain so. Next slide. So one of the key components was the validation of PCR testing, and then continuing to innovate in the testing space. And so that has been evolving, ensuring that we can evaluate new testing methods and understanding rapidly how they can be incorporated in our response. Responding to issues that are emerging and challenges around maintaining testing numbers, particularly asymptomatic surveillance screening is very hard to achieve with the current testing. And so we have developed a saliva test and understanding the sensitivity and specificity of that test, how to use it and how to interpret it has been a key component to further assure ourselves. At this moment, our strategy is very much having low transmission to no community transmission, but very much protecting ourselves from reintroduction of the virus from our ports and returning overseas travellers. We also recognised the importance of serology and developing validated serological assays, whilst the usual way in which tests get developed by Roche and other big diagnostic platforms. But having that original work on developing a validated serological assay was critical to the response. It helped us time infection, which again allowed us to pinpoint our public health action. We also did a lot of work on the customer experience. So one of the other components of the response has been that we've had to engage with the community. We're asking the community to come forward to get tested with symptoms that we would never ask them to get tested for or seek out healthcare. And so to some extent, we had to have a pact with the community that we would make the experience a user-friendly one. Now, at the beginning, there were longer timeframes. People had to self-isolate for longer periods. They were all barriers. So we introduced, I'll talk a little bit later in the presentation about some of the initiatives we put in place. Next slide. As I've indicated, we've known that high testing rates are essential to the response, and we've seen how the absence of testing in other countries has meant that they really haven't had a good handle on the pandemic, and that has led to outbreaks or it getting out of control before they're aware of how widespread it is in the community. So early on, establishing high testing rates and also having testing criteria that's quite generous, recognising the minimal symptoms that COVID can be associated with. So one of the key components has been to modify the traditional testing routes. Things like pop-up clinics, drive-through clinics, a combination of private and public, and working with the Australian government. We also recognised that one of the key barriers was the period in isolation, and also the frustration that people were not getting test results or having to ring up, and those delays meant people were off work for longer, and it just disencouraged people from going back the next time. So what we did is establish an SMS registration process where people could get texted automatically with negative results. And also we have implemented a sort of call line that will follow up those that for whom they're uncomfortable with the SMS registration. This has seen a very significant rise in customer experience, and I think one of the key elements of the response to COVID has also been about the fact that we have to promote when the customer experience is improved. It's also important that we promote those results so that the general view of the community changes, because it's incredibly difficult. Those anecdotes where someone's waited for 3 days or 4 days for a test result can hang around, and so you need to do a lot of extensive communication, and some of that will encompass behavioural elements. So making sure that we say thank you for people that have come forward for a test. Some of those simple acknowledgements of people's positive part in coming forward for testing have been components of this. So very much understanding this as sort of almost a behavioural response, and building those communications and behavioural aspects into our testing strategy. Next slide. This slide highlights the fact that we've had to attempt to communicate effectively. We've had to use a variety of different strategies. We've also had to mobilise the community using peer leaders, engage with GPs, recognise the different drivers for some of the cold communities and what may be their fears and anxieties, and make sure that our communication strategy adequately addresses those, and that we have a deep and rich understanding of the community views and what might be barriers to engaging in testing, or the other health promotion processes like staying off work when you're sick, hand washing, social distancing, and mask wearing. Next slide. I think again this, so New South Wales was hit relatively hard with the first wave compared to other jurisdictions, and that's because we were the gateway to overseas. It's always predicted that Sydney and Melbourne would be the most impacted because we're the destination where most returning travellers arrived. We did have a number of locally acquired cases in New South Wales, and we did commence serological surveys to understand how many we missed in that first wave, and it's estimated that we picked up about 1 in 3 of cases initially. And that was because early on our testing capacity was limited, and while we did have a fairly permissive testing strategy, we still were confined by constraints on pathology as we scaled it up. So we did enter a period after the lockdowns where, looking back, we did effectively eliminate the virus from circulation. And then we had a seeding event from Melbourne as cases rised in Melbourne before we closed the border to Melbourne. This graph highlights the fact that when we identified 2 linked cases who, when we looked back, had both been in the same site in their exposure period, we called out on the public to get tested who had gone to the Crossroads Hotel, and we established a pop-up clinic within hours actually at the hotel. And I think this data shows how the community has responded to those messages. And again, that's a key component of the response, is the engagement with the community to get them to present for testing so that those isolation of the cases and quarantining of their contacts can happen promptly. Next slide. Genome sequencing has been incredibly important, and it has highlighted and guided us about knowing which clusters are linked. It becomes important even today, so I'm sorry if I'm a little bit fatigued, but we've been up throughout the night because we obviously announced today that late last night, we had a case in a person who works at a hotel quarantine. And obviously, urgently now, the question is did that person acquire it through that exposure, through the hotel quarantine? How did they get exposed? But also, could that have been acquired in the community? And so currently the laboratory at Westmead was stood up last night. Specimens were couried urgently. That testing will be complete in 48 hours. So that will tell us the source. So is it related to the Melbourne strains that have been circulating in New South Wales associated from that seeding events from Melbourne? Or is it derived from an overseas traveller? And then concurrently, we'll be sequencing the people at that hotel who turned out positive, again, to help us explore how that transmission event. And so you can see the time criticality of those actions and how important genome sequencing is, but it's embedded in the response. It's not an academic, whilst there are academic elements to it, it is just so pivotal to the response, and the team are embedded with us. The next slide. Just wanted to talk about wastewater surveillance. So early on, clearly some European countries had done some work around wastewater surveillance, and I suppose it's fair to say that early on we were a little sceptical, or I was a little sceptical about wastewater, but I've become a total convert to it. And so this is very much a partnership with Sydney Water, and who has had a long track record in viral testing, and also the University of New South Wales and public health. This involves basically collecting wastewater samples and detecting virus fragments. Now, obviously, its relevance is in assuring it is a tool to assure you that you're not missing unrecognised transmission. And as I've indicated, that because COVID is so mild, if it gets into a very young population, it can be transmitted for many generations before you actually pick it up. If we haven't got those high rates of testing and health-seeking behaviour, this provides a complementary mechanism. Now, there are many challenges with understanding wastewater surveillance because people excrete the virus for a long time. So people that have come in from hotel quarantine, been effectively identified as cases, are released as non-infectious, may excrete the virus in their waste for many weeks after. And those individuals are non-infectious and so go back and reside in the community, but they also may shop and move around or travel somewhere else for work. And so there are a number of challenges in it. It particularly works effectively in regional areas where we're less likely to have a returning overseas traveller in that town. We used it extensively in the border, when Victoria was having lots of cases, for that assurance around the border communities, because we did have a border bubble open at that time. And at the moment we have commenced work on gridding the Sydney catchment to bring it down to much smaller geographical areas of about 10,000, and that will allow a refinement. So yes, last night we also announced there was a positive detect in the Riverstone. We didn't have anyone physically living in that catchment, of that sewage catchment, because we are aware of every case that's been identified across Australia through our shared database systems. And but we do know that there are some returning travellers in adjacent areas, and they've been contacted to understand their movements in the recent week. So the Sydney wastewater surveillance has many research questions associated with it. So it's how many cases in a catchment, what are the confounders that prevent detection. So there's a number of research components to it, but we're also using it to guide our public health response. And I think this is a key factor about how research can be embedded and complementary to the response, but there also can be some more academic questions done over that longer time frame. Next slide. So this shows how we present the data. Clearly, Malabar and the Liverpool catchments the Liverpool catchment has now gone green, and we had a large numbers of transmission events in Liverpool, and that was explaining those. In terms of Malabar, that's confounded because our quarantine hotels are in the catchment of that sewage. So as I said, we are doing some subsetting to give us that granularity in terms to allow us to interpret better the sewage surveillance. But we've actually found it to be very effective, and we think it probably can pick one case in about 10,000 people. Thanks, next slide. So the research project is called Colossus, and just to acknowledge the partners that University of New South Wales, Sydney Water and Health and New South Wales Pathology are partners in that process. The next study I'd like to talk about is the school transmission study. Next slide. So early on, the role of schools was a contested area. Traditionally with influenza and other respiratory viruses, we see children as super spreaders. But on the other hand, schools are important for learning and development. They're safe places. And from an equity perspective, children are often much better at school if we can provide that in a safe way. And so early on, we wanted to generate the evidence to understand if COVID behaved like other respiratory virus such as influenza. Because in the context of influenza, as a control, you would have school closures as one of the response tools. This was critical to informing our policy in relation to school closures, but more importantly, demonstrated our commitment to the community, who was very concerned about sending their children to school in the early phases of the pandemic. Next slide. So this work was led by NCERS, the National Centre for Immunisation Research. And again, it was very complementary to the work that we were doing. So when we were going in and getting a case in a school, we would basically integrate the response team from NCERS into that response, and they would do more extensive testing and serological testing. Basically, this research has been published and contributed significantly to the knowledge base, but interestingly, it shows that transmission in the school settings is actually uncommon. Obviously, as children get older, they behave more like adults in terms of their transmission risk. But this work both in schools and childcare certainly did support our decisions around keeping schools open with a number of COVID-safe controls. Next slide, and I think this is my pause for questions or any interaction you'd like.
Well, thanks, Kerry, for a really fantastic overview of your role, and I think congratulations on the great work you've done both through New South Wales Health and also your contributions to the national approach. We've got time for questions, so if people could either put it through the chat facility. Perhaps I could just start things off a little bit from the brain and mind perspective. So we're hearing, as you said, we've been relatively spared in Australia, thankfully, but we're hearing from our colleagues, you know, the issues of stroke, psychosis, and also the potential fears for longer term neurological conditions, Parkinson's disease. And I know Ian Hickey, our co-director, has been very vocal on the mental health approaches. So I suppose, what do you see in terms of the future, and how are you going about managing these sort of processes, thinking ahead?
So certainly we've been concerned about anxiety, and I think that's been a key approach in schools, about trying to generate the evidence to support and give us comfort, because from our advice is that routine is an important component for children, and also, you know, the challenges of homeschooling fall disproportionately, particularly more challenges for people perhaps in where both parents are working, where there's difficulty in getting time off work, or that work is casualised. And so for those reasons, that was really a key driver for understanding, as a public health physician, I really understand the importance of early learning and schools in well-being. And I think that's been, I think that has been vindicated, that approach. I think we've also got to be careful in our communication. So one of the things about how we communicate, you know, we do want people to obey the rules, and but we also need to not use the fear card too much. And so particularly for young people that might be anxious, worried about what life brings, it's a fine balance. And so I think we need to be cognizant in our communications with them. We also needed to be recognising that young people were affected disproportionately with some of the public health controls we put in place. Things like hospitality, young people often have got casualised employment in those areas. And so I think some of the Commonwealth government's job seeker, job keeper were important in mitigating some of those impacts on young people. But I know that young people were disproportionately affected. Their social networks were impacted, their enjoyment of dance festivals, music festivals, pubs and clubs were changed. And I think we just need to be honest and open about that, and engage with young people. I think young people also potentially had a lot of fear about passing on the disease to their loved ones, but we've also used the fact that they do care about others as a way of getting them to engage. So as I said, this is a very difficult navigation path to not add up needlessly to anxiety generation, but to use some tools to get protective measures in place to allow us to achieve no community transmission. In terms of the longer term impacts, there are a number of studies that I'm aware of that are studying various cohorts, where we will get an understanding of the short and long term cognitive impacts. And I think it's too early to really speculate too much on that. I'm aware of some of the findings that have come out of Greg Dawes' cohort that was linked to the Southeastern Sydney cluster. But I think it's something we've got to be very watchful of. And clearly looking ahead, we've got to look at vaccination and again, how that, you know, the safety signals for vaccination and And again, that will be an area of a significant focus at the moment, getting prepared for a vaccine.
People are writing in the chat room, thanks for a great talk and huge congratulations on all of your hard work during the pandemic. Carol Dobson-Stone has asked, when do you think the 1.5 metre social distancing rule will be retired?
Look, I think it's the 1.5 metre social distancing rule is a guidance, and look, it's one of those, again, ways in which we engage with the community, telling them the science, which the science is the further you are away from the person, the less likely do you catch it. If they're talking loudly, singing at you, whatever, you're less likely to catch it. If you're a distance, you're more like, it's less important and relevant in outdoor environments because the aerosols are dispersed much more rapidly in an outdoor environment. I think these are just measures that we're going to have to probably have for 2021. To some extent, 2021 is going to be a more challenging year. I feel like 2020 has been incredibly challenging, but I actually think 2021 is going to be even more challenging because we're going to have a vaccine at some point. We're going to have vaccinated some of the population. People are going to want to relax the borders. Other countries may have been vaccinated. The risk, we may well have, complacency stepped in. And so how we calibrate our settings for 2021 are similarly going to be a fine dance with the virus until we've effectively got everyone vaccinated. But then even then, we will then be probably dealing with an endemic disease, COVID-19, a bit like flu. And again, we'll have to think about what are some of the measures that we'll want to put in place all the time. Like, we probably do have a bit of a soldiering on culture, a bit too much, like going into workplaces when we're coughing and sneezing. And it's probably now with ability to work from home, prudent that even if you don't go and get a test into the COVID, this is talking about 2022, and when COVID's not so much an issue, we still may be messaging strongly around stay away from workplaces. They're probably viruses and no one else wants to catch them. So I think there'll be some elements of things we've put in place that we want to continue.
Well, thanks, Kerry. Just in the interest of time, we need to move on, but it's had a lot of feedback, your talk, and everyone, there's a lot of virtual clapping and thanking you for your great contribution. So especially for joining us today after being up all night. So we might let you escape, and thanks again for joining the symposium.
Thanks very much. And can I just say that it's very much a team, and the strength of our districts and the strength of our system overall has stood us in good stead, but a long journey ahead. So thank you.